how efficacious the drug is in the practical circumstances. Phase 1 clinical trial usually carried out in normal individuals, human volunteer to examine clinical pharmacology of a new drug. It concerned with safety of the drug in humans and studies drug metabolism, bioavailability, dose ranging, various things are seen in that phase 1 trial. And phase 2 trial, it evaluates effectiveness of a drug based on clinical endpoints, dosing ranges and doses of phase 3 trial, common short-term side effects and risks associated with the drug. So, lots of your planning for your phase 3 trial depends on the results of your phase 2. Okay. And phase 3 trial is the final stage in testing a new treatment in humans, is primarily concerned with assessment of efficacy and safety studied under controlled conditions. I need to spend some time on sort of a controlled conditions, like say that you are not going to rather give the drug just like that, in the market, some patient they come, you prescribe this particular drug and then send him off. Okay. RCT is a control trial in the sense you are certain protocols are there, certain regimens are there for following up, because it is a closely observed treatment like. Okay. And we will be seeing the various aspects of it, how we can it's blinding, masking, and how the endpoints are, whether it is objective or subjective, all those things we are going to rather see, but it is in a very controlled experimental situation, like say as though you are doing an experiment in a laboratory. Okay. And phase 4 trials are post-marketing trials to assess the incidence of adverse reactions and effect on morbidity and mortality in the population. Okay. Any doubt about this phase 1, phase 2, phase 3, phase 4 trials? Now, from now onwards, when I say RCT, it is phase 3 trials. So, the classification of RCT, that's you see when you are telling what such of an RCT it is, that's based on different categories, like type of intervention, that could be either a therapeutic or preventive. Therapeutic, say in the Tuberculosis Research Center, Chennai, have done several RCTs on various drug combinations against tuberculosis, and then they say today this particular combination is 80% effect, and they come out with a new combination, they say it is more efficacious. They try to rather have this 80% drug as a control drug and give a new test drug, okay, and then they see whether it is more than 80%. Okay. This type of a therapeutic trials or phase 3 trials, the type of intervention is a drug. Prophylactic, preventive trials are also called prophylactic trials, the leprosy vaccine trial. Okay. 1,73,400 people are vaccinated. Different, say some people were given vaccination of one type, some were given different vaccination, some were not vaccinated, and they were followed up for 15 years, and then see in each group how many people they developed leprosy. And then they evaluated the efficacy of the protective efficacy of the vaccine. That's all a preventive trial. Okay. So, RCT can be a therapeutic trial or a preventive prophylactic trial. Unit of randomization, either I can rather have individual randomization or a community as such a randomization. Say we did a study on the vitamin A and its effect on the morbidity, say the diarrhea and ARI morbidity among infants. That was a trial we did. We did an individual randomization, individual child is given a mega dose of vitamin A or not. Okay. The same study was done earlier by another group in Madurai, and they did a community. One whole community they gave vaccination, they gave an intervention, and one whole community they did not give intervention. They compared. Okay. So, your randomization can be at the individual level or at a community level. Design, it could be a parallel, crossover, factorial. How many of you are comfortable with all these three? Okay. Parallel is at the same time you are going to either give this drug to some and that drug to the other. Okay. Crossover is the one, the same patient you give a drug once and then the another drug again. See, it's a, for example, for the treatment of asthma, which are recurrent, My first time I am given this drug, second bout I am given a different drug. So within a patient I can rather have A, B, I can randomize that, okay. For some I can give A first and then B next, for some I can give B first and then A next. That sort of a design is called a crossover design. Factorial design is different doses you can rather have among the patients. Say for example, this drug, this dose, drug A, dose A, low dose, high dose, drug B, low dose, high dose. So there are 4 combinations, 2 square. It is called a factorial design. So your allotment is done in a 2 square fashion, which is a statistical design, a factorial design. If you are going to rather do that, it's called a factorial design. The example for that was the tuberculosis prevention trial, the Thiruvallur. They did a factorial design to evaluate the efficacy of BCG in protecting tuberculosis. And so different strains of BCGs and different doses BCGs were rather tested simultaneously. You can get a simultaneous comparison of strain A low dose, strain A high dose, strain B low dose, strain A high dose with a placebo, okay. And you can have a comparison of which strain, which dose is the best as compared to the placebo, okay. That sort of a design is called a factorial design. Then the sample size, fixed or sequential, how many of you know what? Fixed, of course, right in the beginning you will rather evaluate the sample size, your statistician will come and then say, Madam, sir, you have got to rather do 230 people, you will have to give this drug A, and 230 people you have to give drug B. Okay, that's a fix. So your trial goes on till you give 230 patients for A and 230 patients for B. Sequential trial is a one where every individual he enters in, okay, there is a decision rule. Is it enough or we need one more? Okay. Sequentially it's done. Okay. The trial, the design is in such a manner that, okay, every individual, once he enters into it, then we have a decision whether we have to take the next guy or not, or stop the trial there. Okay. This became very popular during the Second World War, because at that time they wanted a quick results, fast results, and the sequential trial, the whole design of sequential trial were developed and improved during the Second World War period. Then the randomization, there are different types of randomization. So I can have one whole lecture session on randomization itself. Okay. How to rather do a randomization, whether there are fixed method, adaptive method, or blocking. You can rather have block randomizations, okay, going for, and it's one of the main reason why we do this randomization is to avoid selection bias. A very well conducted randomized trial have very minimal selection bias, because selection is not in your hand. Okay, it's randomly done. And one of the greatest property of randomization is, randomization has 2 important properties. One, it makes all your statistical tests valid. Later on, when you want to rather compare and do a statistical test, it has to be a random experiment. Okay. Number 2, randomization, what it does is, known or unknown, measurable, non-measurable, okay, all those values they try to rather make it equally distributing between these 2 arms. See, when you are going to rather do matching, you may rather say, I want to rather put this man or sex as one, this age group as one. You may have some limited number of parameters on which you can probably do a matching. You want to rather have the same proportion in these 2 groups. There may be several other factors which you don't know may be influencing, and you may not be probably matching. By randomization, that is done automatically. Then last aspect, it depends on masking. Okay. Masking is also called blinding. Okay. A trial could be a single blind trial. Single blind trials are the patient does not know what treatment he is receiving. That in fact, when you go to any clinician, physician, it is a single blind treatment only. The doctor never says what treatment he gives and what sorts of a diagnosis. Double blind is both the patient and the doctor does not know. And there are triple blind trials. Even the statistician who analyzes does not know. Okay. It is coded and the decoding is done only after the analysis. All the analysis he will be doing drug A, drug B. Okay. You will not know whether drug A is a test drug or drug B is a test drug. Okay. At the end he will say drug A efficacy is this much, drug B efficacy is this much, and drug A is statistically significant than drug B. Then at the end of it they decode and then say whether A is a test drug or B is a test drug. Okay. That is a triple blind, because the statistician can also bias, say I can rather give certain examples of bias in, say, how this at the time of analysis or an interim analysis that can rather. See, there was a trial on an intervention of certain packages, okay, for a pregnant woman, okay, and the outcome measure was the birth weight of a child after delivery. So, the hypothesis is that a particular package is the best one, a high risk approach. So, you get the best result, you get the maximum, say the birth weight is the maximum in that group. Okay. So, this trial was done, it was, and then the statisticians did an interim analysis, okay, and they found that mothers who were not given any package, but the children were weighing more than the so called the intervention mothers. Okay. It was not on full sample size, but it was the investigation was almost rather halfway through, like when we did the first interim analysis. One disadvantage was the principal investigator was also involved in the interim analysis. So, later on what happened, the next half of the study, she went and she blasted all the ANMs. She said, you are not giving this package properly, that, this and all, because if you had given, how can the children be less weight than the children who do not receive any package and things and all. So, the ANMs, they got the message well. They hiked 200 grams, 400 grams more than every child that they measure. So, the second half what happens, the test package, the children were weighing much better than the. So, this bias was introduced because the analysis was done and the analysis person knows which is which package. Suppose if that is coded at that stage, okay, this type of a mistake would not have happened. Okay. So, of course, we will be seeing about that also when we are seeing the interim analysis. Interim analysis is good, but at the same time, you have got to be careful about an investigator bias coming into it. Okay.
Person is doing a double blind study, is not in a position to give the results, or
no, unless it is specifically mentioned in their protocol that they are going to see. It is not necessary that you have to rather do an interim analysis again and again. Say the protocol may say at the end of 1.5 years we will do an interim analysis. Okay. Could be your protocol, and they will have to adhere to that protocol.
It was not mentioned in the protocol. So, I was just wondering, because I was reviewing the results of the first annual report, which was absolutely not given. So, that is why.
In fact, that is one of the component of the protocol, stopping rules, Okay. So, when to do an interim analysis, they are all a part of your protocol. So, in observational studies, the statistical method allow investigators to control for confounding factors. But what is one of the criteria for that? See, in observation studies, there are confounders. I said you need not worry about confounders. You will have to worry more about bias, not the confounders. Confounders could be tackled even at the time of analysis. But for me to tackle in the time of analysis, what should be done? I should have information about it. Okay, I should have information about it. I should have measured it. Okay, if sex is a confounder, in my data set, I should have the sex as one of the parameters in it. Suppose if I have not rather noted whether it is a male or a female, I can't adjust it in my analysis. So my data should have that. Okay. So now let's rather I said RCT is something really good, but it requires a tremendous amount of methodological rigor. Improperly conducted RCTs are, it's an enormous resource waste. You can rather improperly do a case control study, a cohort study, that's no problem. Okay? But if you do an improper RCT and at the end of the very stressful 1 year end, the RCT, and somebody looks at it, it said, you know, there are lots of bias in it, it is not done properly, it's waste, it's a huge resource waste. Okay. So researchers must devote assiduous attention to design and conduct of RCTs.